All right, so let's dive in. The thyroid. It's this butterfly-shaped little gland in the neck, right? But oh gosh, its role in metabolism, growth, even development, it's just massive. I mean, without it functioning properly, the whole system goes haywire.
Absolutely. The thyroid produces those crucial hormones, T3 and T4, that regulate metabolic rate, energy production, and even protein synthesis. Disorders here, such as hypothyroidism and hyperthyroidism, are among the most common endocrine conditions we encounter.
Exactly. And hypothyroidism, let's talk about that for a second. It often stems from things like Hashimoto's thyroiditis, an autoimmune condition, or even iodine deficiency, which, still affects a lot of people globally. And when the thyroid hormone tanks, we're talking fatigue, weight gain, cold intolerance. The list goes on.
Right. And managing hypothyroidism effectively usually involves levothyroxine, a synthetic form of T4. It's fascinating how this drug works. It replaces what the thyroid isn't producing, then the body converts it to T3 for cellular use. But it's quite precise, isn't it?
Oh yeah, precise. You've got to take it on an empty stomach, same time every day. And there are interactions like antacids and calcium supplements that can, mess with absorption.
And let's not forget, incorrect dosing can lead to symptoms of either undertreatment or overtreatment, ranging from lethargy to, at the other extreme, palpitations, even arrhythmias in some cases.
Arrhythmias are no joke. And this is where nurses really step in, right? We monitor therapeutic effects, identify side effects, adjust doses with the provider. It's the whole package. But we can't talk thyroid without also mentioning hyperthyroidism. That one's a beast in its own right. Graves' disease as the poster child.
True, particularly with Graves adding those extra symptoms like ophthalmopathy. For hyperthyroid patients, we're looking at methimazole, or less often, propylthiouracil. Both inhibit thyroid hormone synthesis effectively, though methimazole is often preferred due to its longer duration of action.
Yep, and here's a reality check for nursing students listening. You've got to know the side effects. Agranulocytosis, anyone? I mean, we're talking life-threatening drop in white blood cells. These aren't just medications. They're meticulous balancing acts.
It certainly emphasises the necessity for careful monitoring, regular blood tests to adjust dosing and track side effects. And beyond the medical, there's the human side, educating patients, ensuring they understand their medications and the symptoms to watch for.
Exactly. There's so much detail to grasp. The diagnostic process, the tailored management plans. It's no wonder students feel overwhelmed sometimes. But this stuff, it could save lives. So, while the thyroid is a critical player in the endocrine system, it's just one part of the puzzle. Let's switch gears now to another powerhouse, the adrenal glands. These tiny structures sit atop your kidneys, right? They're like multitasking marvels, producing hormones that regulate stress, blood pressure, glucose levels, even metabolism. But when they misfire, chaos.
Absolutely. The adrenal cortex alone produces glucocorticoids like cortisol, mineralocorticoids such as aldosterone and androgens. Then there's the medulla with its catecholamines, adrenaline and noradrenaline. This balance is crucial because when there's dysfunction, it can affect nearly every system in the body.
Oh, and speaking of dysfunction, let's dive into Addison's disease for a moment. It's a classic case of primary adrenal insufficiency. Autoimmune adrenalitis is the big culprit in developed countries. Patients come in looking, tan even without sun exposure. There is increased ACTH, and they're fatigued, weak, weight loss, low blood pressure. It's a lot.
It truly is. And that hyperpigmentation is so telling. Of course, the critical issue here is cortisol deficiency. This hormone is vital for stress response, maintaining blood pressure and glucose levels, and more.
Exactly. And without enough aldosterone, potassium skyrockets, sodium tanks. It's electrolyte chaos and dangerous. Enter hydrocortisone therapy. It's game-changing. Tailored dosing mimics normal diurnal variation, higher in the morning, lower at night.
Right, because we're essentially restoring what the body can no longer produce. But it's not just about prescribing hydrocortisone. Monitoring for side effects, things like weight gain, hypertension, and even adrenal crisis if therapy is interrupted. Nurses play a pivotal role in all of this.
Oh yeah, no pressure on us, right? But seriously, adrenal crisis. That's like emergency level cortisol deficits. It's chills, fever, a sharp BP drop. It's scary. And patients need immediate IV hydrocortisone and fluids to stabilize.
Precisely, which is why patient education is so crucial. Ensuring they know to double their dose during a stress event or when to seek urgent care, it can make all the difference. But what about the other end of the spectrum, like Cushing's syndrome?
The total opposite problem. Cushing's is from too much cortisol, either from a tumor pumping out ACTH or, long-term glucocorticoid therapy. These patients present with central obesity, that classic moon face, buffalo hump, bruising, muscle weakness. It's overwhelming.
And the systemic effects are just as debilitating. Impaired immunity, osteoporosis, even neuropsychiatric symptoms. For treatment, addressing the underlying cause is key, whether it's tapering corticosteroids or removing a tumor.
But those taper guidelines are so tricky, right? Go too fast and you risk secondary adrenal insufficiency because the hypothalamic pituitary adrenal axis is suppressed. It's all about the balance here, folks. Speaking of systemic effects, let's transition into metabolic bone diseases like osteoporosis, which, by the way, affects millions globally. Sometimes you'll even see it secondary to conditions like Cushing's syndrome. It's all about imbalanced bone remodeling, right? The osteoclasts start overperforming while osteoblasts just can't keep up. And boom, fragile bones that fracture easily.
That's correct. Osteoporosis reduces bone density and compromises bone microarchitecture, thinning trabeculae and increasing porosity in cortical bone. It's so pervasive, especially among postmenopausal women, largely due to estrogen deficiency, though aging and medications like glucocorticoids play significant roles too.
Exactly. And the clinical repercussions. Vertebral fractures, hip fractures, chronic pain. It's horrible. Nurses in these settings, we see firsthand how destructive this disease is. But treatment-wise, we've actually got, a decent arsenal to slow or even reverse the damage.
Yes, starting with bisphosphonates, which inhibit osteoclast activity. They bind to bone surfaces and disrupt the bone resorption process. These drugs are the cornerstone of osteoporosis management, decreasing both vertebral and hip fracture risk significantly.
Totally. And those oral ones, alendronate, risdronate, they come with all these rules, right? Fast for an hour, sit upright, no mixing with anything else. Oh, and GI side effects. They're common. But IV formulations like zoldronic acid, game changers for compliance.
True, but they're not for everyone. Then there's teriparatide, a recombinant parathyroid hormone analog. It's fascinating because, unlike bisphosphonates, it stimulates osteoblast activity, promoting bone formation rather than simply reducing resorption. It works exceptionally for severe cases.
Oh, I love the science behind teriparatide. Daily injections can drastically improve bone density in those who fail first-line therapies. But it's pricey, and it's capped at 2 years of treatment, so you've got to optimize everything while you're on it.
Cost is a challenge. And we can't forget SERMs like raloxifene. These provide estrogen-like benefits to bone, particularly in postmenopausal women, without stimulating breast or uterine tissues. They reduce vertebral fracture risk, but their effect on non-vertebral fractures is less robust.
Yeah, and SERMs increase the risk of clots, so they're not ideal for everyone. Oh, and speaking of calcitonin, it's kind of the backup quarterback in this lineup. Not as potent, but sometimes it's useful. It's also got nice analgesic effects for acute spine fractures.
Indeed, though its routine use has diminished, it can complement therapies in certain scenarios. Beyond drugs, though, there's so much we as nurses can do. Educating patients on calcium, vitamin D, weight-bearing exercise, and fall prevention strategies. These make a huge difference in outcomes.
Couldn't agree more. Empowering patients to take control of their bone health. It's like the foundation of good care. You know, this has been such a rich conversation. Endocrine disorders are dense, complex, but absolutely critical for quality nursing care. I hope our listeners feel a little more confident tackling these challenges.
Yes, and that's truly what it's about, equipping healthcare professionals to think critically and act effectively. And on that note, we thank all of you for tuning in. It's been a real pleasure exploring these important topics together.
Absolutely. Loved every second. Until next time, take care and keep learning.